Going a little bit further down, I want to talk a little bit about hyperthyroidism. I want to talk about etiology. So once we see a patient and they have consistent symptoms and signs consistent with hyperthyroidism, we should think about the most common causes. The most common causes being things like Graves' disease. That's the most common one, especially in young patients. And then the other one that we see in older patients is the toxic multinodular goiter. So that's the second most common one that we see. But we see some other forms of hyperthyroidism. They may not be the type of Graves' disease, but they are clinical. Clinically, the patient presents with hyperthyroidism in these cases too. And this is subacute thyroiditis. I just showed you a case of that, how they presented, or de Quervain's thyroiditis. That's another name for it. And then there's extrathyroid sources, like thyroid toxicosis factitia, where people are taking exogenous thyroid hormones, and stroma ovari, where these people have these tumors. They produce either T3, T4, or TSH, and excess TSH from the pituitary is very, very, very rare. So I want you to know the Graves' disease, the most common one. The second most common one that we see is toxic nodular goiter. And I want you to remember a little bit about subacute thyroiditis and factitious thyroiditis, because they also present with hyperthyroid syndromes, hyperthyroid clinically syndromes. So Graves' disease, we said, is the most common form of hyperthyroidism. Now, the typical triad that these patients present with is hyperthyroidism plus a big diffuse goiter on the exam, and then exophthalmos. Exophthalmos is clinically, it's called proptosis. It's the same thing. Exophthalmos and proptosis, they're talking about the same thing. And I want to make sure you understand that the Graves ophthalmopathy, the exophthalmos, the proptosis is only seen with Graves' disease. There's no other disease that you see this with, no other thyroid disease. So please, if they show you a picture with the patient with the bulging eyes, they have that kind of like wicked stare, the typical Graves' disease patient, and they ask you what form of hyperthyroidism is this, it's only Graves' disease. It only occurs with Graves' disease, can't occur anywhere else. The typical scenario is it occurs in women, usually in their 4th decade, but it can occur earlier or later, and it occurs sometimes in men. Now, the premise of Graves' disease is that this is an autoimmune disease. You have autoantibodies formed against the TSH receptor, and I shouldn't say against the TSH receptor, I should say antibodies that latch on and activate the TSH receptor. Now, this is important because basically these are the antibodies. They act like TSH, and what they do is they activate the TSH receptors on the thyroid, and that's why you get the diffuse enlargement. It's basically like having excess TSH in the body when you have these antibodies. Now, these antibodies, I want you to remember them because they've asked questions about them. These antibodies are called TSIs, right here, TSIs, or thyroid stimulating immunoglobulins. So that we see those in about 95% of the cases in Graves' disease. And when we have any question about Graves' disease, this is one of the extra tests that we do to confirm the diagnosis. We look for these antibodies, autoantibodies, thyroid stimulating immunoglobulins. So really, Graves' disease is an autoimmune disease, and the nature of the disease is that it comes and it goes, just like other autoimmune diseases like lupus. So it has exacerbations and remissions. Now, these patients also have autoantibodies that cause the ophthalmopathy, the extraocular muscle antibodies. And one of the things that they ask us on the boards is, after treatment, after we treat the patient with Graves' disease, are there any of the symptoms and signs that get worse in a patient with Graves' disease? This is after treatment, after we're treating the patient with Graves' disease, and the answer is yes. The Graves ophthalmopathy, the Graves exophthalmos, the Graves proptosis sometimes gets worse despite treating the patient with Graves' disease. So all the other symptoms get better, but the eye manifestations commonly get worse. And the reason they get worse is because they have a life of their own. There's autoantibodies specific for this disease, and whether they get better or they get worse or they stay the same, it's basically on their own. It has nothing to do with the treatment of the Graves' disease, the primary Graves' disease. Because it's an autoimmune disease, because Graves' disease is an autoimmune disease, we also see it commonly with other autoimmune diseases, like pernicious anemia and myasthenia gravis. So it's common to see patients with Graves' disease to develop earlier or later B12 deficiency from pernicious anemia and so forth. So look for that, because autoimmune diseases, they kind of go together. If you have one, you are likely to get another one. Now, the presentation of Graves' disease is the nervous system, the nervous symptoms, the nervous system symptoms where they get jittery and they have they get tachycardia, like cardiovascular disease, and especially in older patients, they have a myopathy, where they have proximal myopathy, where they have difficulty standing and picking up things. And then they have the tremors and the inability to sleep at night. They may have diarrhea, sweating. Heat intolerance is very common, especially in warm places, and they have weight loss. Typically they have weight loss. Some of these patients, about 8 to 10% of them actually don't lose a lot of weight, or they gain a little bit of weight because they have so much hyperphagia, they eat so much. But the typical scenario, 90% of the cases, is the weight loss. And they sometimes have a form of congestive heart failure called high output failure, which causes the typical heart failure symptoms of palpitations, dyspnea, shortness of breath, and so forth. A couple of other things that these patients have: they may have the palmar erythema, which is typical, and they have a form of lower extremity edema called pretibial myxedema. Now they sometimes ask about this on the boards, because when you hear the word myxedema here, your mind goes exactly to hypothyroidism right away. But this pretibial myxedema, this thickening, non-pitting edema, it's initially pitting and then it develops to non-pitting edema in the lower extremity, usually confined to below the knee, is typical of Graves' disease. So look for that. They show you sometimes a picture, right, and they show you the proptosis, and then they show you the swelling of the legs, just to kind of get you to think about myxedema and hypothyroidism. No, this is a presentation of Graves' disease, so don't miss that. A couple of things for the diagnosis. In most typical patients presenting with the proptosis and so forth, all we need to show is a suppressed TSH, a low TSH, and the free T4 elevated. You don't even have to get free T3. So that's a $300 test that you don't have to get here. All you have to do is get a free T4 and a TSH. The TSH is low, the free T4 is elevated, and in the patient that has proptosis, because I said it doesn't occur anywhere else, in no other disease, then you have the diagnosis and you don't have to go any further. The radioactive iodine uptake is usually not needed. If there's questions about the diagnosis, if the patient doesn't have proptosis, if the patient doesn't have the typical presentation of the big thyroid that's very vascular, then you do the radioactive iodine uptake to see if this patient could have maybe not Graves' disease, but subacute thyroiditis or toxic nodular goiter, or something other than Graves' disease, because it changes what you do for that patient. So the radioactive iodine uptake is needed only in the cases where there's a question about the diagnosis. And if you do the radioactive iodine uptake in the patient with Graves' disease, what you see is diffused increased uptake throughout the whole thyroid. That's important. So if they give you the typical radioactive iodine with Graves' disease, diffuse uptake throughout the whole thyroid. If it's not diffuse uptake and it's nodular uptake, regional uptake, they're talking about toxic nodular goiter. If it's decreased uptake, they're talking about subacute thyroiditis. The thyroid stimulating immunoglobulins, I told you, are the antibodies that we see in these patients in 95% of the cases. And they confirm the diagnosis, but we don't usually need them because they don't help us out a lot. We don't really do anything. Sometimes some people get them to see if the patient has recurrence of disease later. You may do that, but generally for diagnostic reasons, it doesn't help us only in the rare cases. Despite doing all the other stuff, the radioactive iodine, if we still have a question about the diagnosis, we may do the thyroid stimulating immunoglobulins to confirm the diagnosis, but generally speaking, it's not needed.